On behalf of the Wisconsin Institute for Public Policy and Service and UW-Marathon County, I would like to thank you for coming to this presentation on the Affordable Care Act with Dr. Marty Finkler. This event is part of the WIPPS Public Issues Series. My name is Julie Bunchek, and I am the WIPPS Program Manager. The Wisconsin Institute for Public Policy and Service is a unit of the UW Colleges and UW Extension and was founded in 2007 here in Wausau. Our mission is to address local, state, and national issues by linking public scholarship, civic outreach, and student service to enhance community life throughout Wisconsin. We believe that the strength of American democracy in the 21st century depends on the engagement of citizens and communities in making decisions about issues that matter to them. To this end, WIPPS' task is to provide resources, information, and ideas to empower the people and communities of Wisconsin. Tonight's program would not have been possible without the hard work of our entire WIPPS team, particularly our Director, Eric Giordano, WIPPS Health Policy Fellow, Dr. Corey Norbaum, Marketing Director, Deb Dorhorst, and our wonderful team of interns. We are also grateful for technical support from theater technicians Chris Berg and Tim Newmeyer. The Public Issues Series is made possible through the support of Dean and C. Ann Dietrich and Kevin and Wendy Hermenning. Dietrich and Hermenning are Wausau businessmen who are committed to open, nonpartisan dialogue. WIPPS has a couple of events coming up. We are a partner in the Toward One Wausau project, which is aimed at facilitating community dialogues around the issue of cultural and racial diversity. We have several dialogues scheduled for the next 6 weeks. Flyers are available at the WIPPS information desk as you exit the building. Also on May 16th, we will host a day-long conference, Addiction, It's Everybody's Business, featuring several nationally recognized speakers. More information can also be found at the information desk as you leave the theater. Following Dr. Finkler's presentation, there will be time for questions. We will have students on hand with microphones. If you have a question, please raise your hand and someone will bring a microphone to you. We are recording this event in order to share it on our YouTube channel, and using the microphones allows us to capture questions on the recording. At this time, please check to see that cell phones and electronic devices are silenced. And if after our program tonight you are inspired, moved, pleased, or otherwise enjoyed the event, we encourage you to make a donation to WIPPS. We are a self-supporting organization and depend on the generosity of our supporters to survive and thrive. Your support will help secure the continuation of WIPPS as an organization, as well as ensure future programs like the Public Issues Series. Donation envelopes can be found at the WIPPS table as you exit the auditorium. And now I would like to introduce Dr. Corey Norbaum, WIPPS Health Policy Fellow, who will introduce our guest for this evening.
Good evening. Dr. Marty Finkler retired in 2016 from Lawrence University in Appleton. He has taught a variety of courses related to health policy and the economics of medical care. His 37-year career with Lawrence went beyond the scope of teaching. He was the driving force in launching Lawrence's successful Innovation and Entrepreneurship program, as well as one of the architects of the university's popular interdisciplinary Sustainable China program that connects the classroom to on-the-ground experiences in China. He was selected as the Robert Wood Johnson Faculty Fellow in Healthcare Finance in 1986, and also spent 1 year as a Robert Wood Johnson Fellow with Kaiser Permanente Medical Care Program. Dr. Finkler established Innovative Health Associates as a healthcare consulting firm which worked with physician groups, healthcare systems, health insurers, and health insurance agents. I was first introduced to Marty in April of 2013, and later that year, he was the keynote speaker at a WIPPS forum entitled It's Here, the Federal Health Insurance Marketplace in Wisconsin. Since then, he's been a great mentor and friend to me and to WIPPS. I've learned a lot about population health from my economist friend. Things like the triple aim that I was not in tune to prior to that, and that incentives are involved in everything. We've been working together on developing a community health community health business partnership here in Marathon County. Last summer, Marty was named Senior Economics Fellow here at the Wisconsin Institute for Public Policy and Service. And it is my pleasure to introduce him as our featured speaker tonight.
Thank you, Corey, for that very kind introduction, and thanks to all of you for coming. Let's hope that the technology works for us tonight. So I'm going to talk a lot about the details of the Affordable Care Act. It is not simple, which is why it can't be chucked so easily. And I'll talk about some of the features of it. Actually, tell you exactly what I'll talk about. Some of the key provisions that exist in the Patient Protection Affordable Care Act, otherwise known as Obamacare, its impact on a variety of things: access, cost, quality, and choice. Some of the things the gaps that it has. There's no one who says it doesn't need to be repaired or reformed or adjusted or fixed in various ways. I'll talk about some potential responses to these gaps. As you might have guessed, about 2 weeks ago, my talk changed because one of the potential responses sort of didn't make it, right? And then I'll offer some final comments and conjectures. But as a preview, here's one conclusion that I think is pretty interesting. So what I'm going to argue, among other things, is the forces for repeal and figure out the next steps later may be too great for serious bipartisan legislation, even if it complicates the ultimate goal of repeal and replace. Gail Walensky is a health economist who was actually on the first President Bush's staff at one point in time. So what I'm going to argue is until we can find that bipartisan approach, we're not going to have a sustainable reform. So let's get on and talk a bit about the Affordable Care Act, or quite a bit about it. Probably more details than you want to know, but we'll do that anyway. So the Affordable Care Act essentially stands on a three-legged stool. You knock out one of the legs and it falls apart. The three legs are an insurance market reform. So that reform leads to the notion that you cannot have any exclusions for particular conditions, and effectively what it means is that the plans that get submitted have to be based on the character of the community. They can't be experience related. The second thing is mandated purchase by individuals and businesses, and if you don't purchase, then you face a penalty. And the third piece is a lot of folks won't be able to afford such a program, so we need two different kinds of ways to help them do that. One is subsidies of various sorts, and the second is to expand Medicaid. So that's what we've done. There are other pieces to the program. This is a 906-page piece of legislation. So there's a lot regarding delivery system reform and payment reform, some of which relates to cost control, but those are experiments and demonstrations and not really on center stage yet. Okay, so the Act has 10 different sections or titles to it. For the most part, the discussion has been about titles 1, 2, and 9. So 1 is the individual market, the federally facilitated exchanges. 2 is about the expansion of Medicaid, and I'll talk a lot about that in a little bit. And 9 is they got to fund this. So those are the critical pieces to it. These are just a few of the provisions, and I'm not going to go through it in great detail. If you have questions about it, we can come back to it. So no exclusions for pre-existing conditions, no limits on the amount of liability that would be covered under the insurance. These are all new things. The individual mandate, both for individuals and for companies, the employer mandate. Subsidized insurance through the market exchanges. It's important to note that the only way that the subsidies are available is if people sign up through the exchanges. And there are really two sets of subsidies. There's a premium subsidy to purchase the insurance, and if your income is relatively close to the poverty line, then you also get the co-pays and the deductibles are also subsidized, up to 250% of the federal poverty line. So those are important provisions. There's 10 essential benefits. This has been a debate currently this week. The attempt by folks in Washington to see if they can resurrect something that might be difficult to do. A lot of it focuses on changing the nature of the 10 essential benefits, and I'll show you what those are in a moment. Children are covered under their parents' policy until age 26. That's actually one of the cheaper provisions. There's the federal funding to each state that chooses to participate, complete funding for 2 years and then 90% after that to expand Medicaid coverage up to 138% of the poverty line. The Supreme Court in 2012 said that can't be imposed, it's optional, it's up to the states. I'll talk a bit about that later as well. There are a variety of experiments, payment programs, and delivery system reforms. There's a restructuring of Medicare Advantage. Some of you may have heard of the donut hole that exists in the way that the Medicare Part D drug coverage is set up, where after a certain number of dollars, I don't remember exactly what it is, somewhere between $2,500 and $3,000, your coverage goes to zero and then it kicks back in at about $5,800. So this act closes that gap over a period of time. So there's lots of different provisions. There's what's called the Cadillac tax. So if the cost of the premium is above a certain level, it gets taxed at a 40% tax. That keeps getting postponed. It initially was 2018. It's been postponed to 2020. The American Health Care Act, the Ryan bill, postponed it to 2025, so this may never see the light of day. So if you really want to know the details, there's a 13-page single-space summary, so you don't have to read all 904 pages. In your spare time, if you need something to put you to sleep, that might help. Okay, so the 10 essential benefits. The idea here, again, I don't need to go through all the details, but the idea is to make these plans that participate in the exchange look like a standard or typical employer plan. And these are the kinds of benefits that are covered. The debate the discussion this week is to allow states to maybe get a waiver to weaken some of these things, not offer maternity care, not offer mental health, not offer prescription drug coverage. I'm guessing if that required an act of Congress, it isn't going to get through, but, that's speculation, right? Okay, so what we know is the American healthcare system is not very efficient. One picture of that is to plot on the horizontal axis the expenditures per person and plot on the vertical axis life expectancy. And you can see that the U.S. is way off. So to the point way to the right, off of the curve, almost every other country, at least in the developed world, is somewhere near the curve. There are two things about this. One, the U.S. is way off, so that means we spend a lot more relative to life expectation than other countries do. And the second is, as you spend more and more, the benefits in terms of additional life expectancy gets smaller and smaller. Economists call that diminishing returns. The Institute of Medicine estimates that roughly 30% of what we spend is wasteful. So that's about $1 trillion a year, just to put it in round numbers. Or put differently, we have a system, only in America do we still pay the most to have the least health. Now, one comment on this, we tend to measure, to look at things because we can measure them well. We know about life expectancy, but health has to do with a lot more than just life expectancy, but that's obviously a lot harder to measure and to agree upon. Okay, so one of my heroes or favorite economists is Uwe Reinhardt at Princeton University. And I think he's captured our system and the way we think about it really well. So I want to read from a short quotation that he has. Americans have an instinctive distrust of government and have faith in private markets. Yet, Americans are unwilling to accept the harsh verdicts of markets. Thus, we get the following result: a bewildering system of half-hearted competition and half-hearted regulation. This approach encourages in healthcare an economic free-for-all in a highly imperfect market, which increasingly turns patients into blindfolded shoppers, thrust into a healthcare shopping mall that's only haphazardly controlled by ad hoc, often mutually inconsistent regulations that further distort the healthcare market. That's pretty complex. Now, one of the distortions, and in fact, one of the biggest opportunities, is to gain a sense of what we subsidize and who benefits from that subsidy. So as this chart from the Congressional Budget Office highlights, the employer-sponsored insurance is exempt from the income tax. So if you get paid in salary, it gets taxed. If you get paid in insurance, it doesn't get taxed. So the amount of that in the current year is about, if we collected a tax on that the way we collect a tax on other income, we would collect an additional $268 billion, or over the next 10 years, in excess of $3.6 trillion. Okay? The Medicaid expansion, so the existing Medicaid program, the child health insurance program, not the parts that the state funds, not the parts that cover people that are in nursing homes, but the under 65 parts, is a similar magnitude. So those are big numbers. The third line here, non-group coverage in basic health care, this is what it costs us to fund the insurance part, the subsidies for the exchanges. So that's $48 billion. And there's some other pieces as well. But the point here is we spend in foregone income taxes $660 billion per year on health care. Now, this chart shows a couple things. One, the benefits of these expenditures have been rising over time. And two, the vast majority of the benefits accrue to people in top income categories. The people in the bottom income categories often don't have insurance, right? So looking at this chart, I calculated if you look at the top three groups, so the top 30% in terms of family income in the US, 56% of the benefits accrue to this from the employer-sponsored insurance. That's $150 billion. If we look at the bottom 30%, that's 6% of the benefits. So let me now turn to the Affordable Care Act, and this slide just summarizes what I'm going to do in the next few slides. So I'll give you a flavor of where it's gone and where we're likely to go. So we have had expansion in 31 states that's led to, one of the things that I'll have to tell you about is I can only look at that screen back there, which I can't read. So I'm looking at my notes at the same time unless I look back at the screen. And one of the things I've learned teaching for many years is I don't want to have my back to the audience reading the screen. So bear with me a little bit on that. Okay, so let me give you the summary a little bit. So the number of uninsured has declined by 23 million since 2010. The states that expanded Medicaid, that took advantage of the option to expand up to 138% of the poverty line, showed the largest declines in percentage of population uninsured, the declines in the percentage of folks uninsured. Health plan exchanges have existed in most places, though it's declining. This is the debt spiral discussion that we'll have in a little bit. So in 2017, 21% of the population in the US had access to only one insurance provider. In Wisconsin, however, it's pretty good. 58 counties have at least 3 insurance providers. 13 counties have 2 insurers, and 1 county, Menominee County, which is the Indian Reservation, has just 1. So the notion of not having competition in the insurance side is really not an issue in Wisconsin. Another thing that's taken place is expenditure growth in medical care has been reduced relative to what it was in the past. Now, how much of that can be attributed to the Affordable Care Act and how much to other things I'll talk about in a little bit. But the main beneficiaries, without any doubt, of the Affordable Care Act are folks that are relatively low income and are relatively unhealthy. There also are several measures of quality that I'll talk about that I think are pretty interesting in how they've improved. Okay, so the first chart here goes back to the number of uninsured. And what you'll see is two different lines. The first one, they implemented the idea that the children could stay on their parents' policy until they're age 26. They implemented that right away. And you can see the effect going from roughly 35% of those between 19 and 26 that were uninsured dropping down to around 15. And then the exchanges were implemented in 2014 and the Medicaid expansion in 2014, and that dropped the population age 27 to 64 from about 20% down to 12% in terms of the percent of the population that's uninsured. The beneficiaries, clearly the folks, the bottom part of the chart says those less than 138% of the federal poverty line. Again, many of these people became eligible for Medicaid, for the expanded Medicaid in the states that offered that. But you can see that the percentage of those who are uninsured dropped by a full 10 percentage points. And the people between that line and the 400% line, so you still can get some premium support up to 400% of the federal poverty line if you're participating in the exchange. There's also a big move there. And if we look at the middle part of this graph, you can see that the non-white population was also a huge beneficiary of some of these policies. So for blacks, the percentage drop in the percentage of people, the percentage point drop in the percentage of people who are uninsured was 7.7 percentage points. And if you look at Hispanics, it's almost 10%. So it's had a big effect on those communities in particular. Okay, now let's take a specific look at Medicaid. And again, I'm going to state on this slide some of the results, and then I'll show that a bit on the next few slides. So 31 states chose to expand their Medicaid program based on the offering from the ACA. 19 states chose not to. The District of Columbia also decided to expand. And that led to 10.7 million newly eligible people, plus some people who were previously eligible also decided to join, partly because of the mandate that if you don't have insurance, you have to participate. I mean, you have to pay a penalty. So that led to 14 million people that have been added to the insurance rolls that weren't before. 7 states used a waiver provision that exists in the law to ask the federal government if they could change the way they implement the Medicaid program. And I want to talk about 3 of those, 3 states in particular. 2 used the waiver, 1 did not, and then indicate that there are several states, the next slide actually will show this, several states that are thinking about it now and have taken some action toward expanding Medicaid. So the 3 states I think that are interesting in what they did are Arkansas, Indiana, and Wisconsin. So what Arkansas did is to say, can we use our Medicaid money to help people below the poverty line participate in the exchanges, and we'll just use our money to subsidize their participation, so we have one program. That's one kind of approach. Indiana, under Mike Pence and Selma Verma, who's the new head of Health and Human of the Center for Medicaid and Medicaid Services, designed a program in Indiana, which also took the expansion and asked for some ways they might implement it. They want to encourage health savings accounts with the program they have. There also is some fees to participate in the program. They're not huge fees, but there are some fees so people take it seriously. So that's the second program. The third kind of program, Wisconsin and Governor Walker basically said, look, we don't want to have a gap where people don't have a choice of some program. But we also don't want to expand Medicaid where there is another program that's available. So what he did was say with Badger Care and Badger Care Plus, we're going to say anybody who's above the federal poverty line, we're not going to have Medicaid for them anymore, or Badger Care. But anybody who's below the federal poverty line qualifies for Badger Care. Because if you're above the poverty line, you can participate in the exchange, and if you're just above the poverty line, up to 138%, you get some pretty good subsidies, which I'll show you in a moment. Okay, 19 states rejected federal funds totally. Again, these expansions were covered in full for the first 2 or 3 years, and then up to 90% after that. 19 states decided not to expand at all, and one result of that is there's a gap in many of those states, which leads to 2.6 million people who have no option, neither Medicaid nor can they participate in the exchange. So in Florida, over 1 million people of this 2.6 million fall in that gap. That's in Texas. Over 1 million in Texas, almost 750,000 in Florida, and almost 500,000 in Georgia. Those 3 states in particular make up most of, they don't have an option. So they didn't change below the federal poverty line to cover everybody the way Wisconsin did. They just left it the way it was. Okay, so here's a picture of the states. You can sort of see how concentrated they are. The blue states expanded, the yellow ones did not. I don't know if you can read it or not. Yeah, there's some asterisks in some places, and there's a caret, like you can see Kansas in the middle, there's a little caret beside it. There are 4 states that have made some steps since the start of the year to think about expanding. Kansas went as far as both houses of the legislature passed expansion. The governor vetoed it. They came back to think about overriding the veto, and they came up 3 votes short. But Kansas, Maine, Virginia, and North Carolina all have taken some action to try to think about expansion. So what are some of the effects of the Medicaid expansion? Well, one of them is the rates of uninsurance drop more in the states that expanded than in those that did not. You can see that from the blue line relative to the green line. So along the horizontal axis, you have what the uninsurance rate was prior to the implementation of the exchanges and the Medicaid expansion. The vertical axis is the percentage points of decline in the uninsured rate. And you can see that the blue line lies above the green line. It's also steeper. One of the reasons why the uninsured rate dropped a lot is in the states that didn't expand, the people between 100 and 138% of the poverty line who were ill decided to participate. Well, actually, that's pretty much because they didn't qualify for Medicaid in those states. Many of them decided to participate in the exchange. If they were ill or relatively sick, then it would mean the premiums in those states would have to be higher to cover those people. So what we find is that there are higher premiums and higher growth in premiums in the states that didn't expand than those that did. Okay, so this is a chart of who's not covered yet, right? And I mentioned the 3 states, the major part. So that 2.6 million in the bottom, the orange slice, those folks have no option available to them. The 43% on the right-hand side, those are people who could take advantage of subsidies in the various states that are available. So either they qualify for Medicaid, but they haven't taken advantage of it. They'd qualify for subsidies under the exchanges. They may even qualify for the cost-sharing reduction subsidies that are available. This chart isn't per se related to Medicaid. This is overall the rate of growth of medical care expenditures since the beginning of the century. And we can see that the rate of growth has dropped off. Now, in particular, it's dropped off between 2010 and 2015. It's grown back. 2016 is a little higher. The numbers just have been in recently. For the most part, I think this has very little to do with the Affordable Care Act. There are 2 things that drove it. One, the economy wasn't in very good shape. It took a long time for employment to kick back up and employer-provided insurance to kick back up. And 2, the growth in health savings accounts and high-deductible policies took off, which effectively said to people, if you're going to spend money, it's got to come out of your pocket, and a lot of people said, I'm not going to do that. So there was some break on the amount of expenditures in the short term as a result of that. Now, the role of deductibles is a huge deal. So this chart shows 4 lines. The bottom one is how much prices on average have grown, 6%, since 2011. The second line is how much wages have grown. The third line up, the purple line, is how much health premiums have grown. And the fourth line up is how much deductibles have grown. So what we have is a huge cost shift of who's paying for the services that are provided. And obviously and some of these are quite large, as I'll show you in a little bit. Okay, so now let's take a look at what the market exchanges have done. So as of January 31, 12.2 million people were enrolled in the exchanges. Roughly, 36% of those are between the age of 0 and 34, 37% between 35 and 54, and 28% are between 55 and 64. The subsidies that I was talking about previously come with the silver level purchase. Now, the silver level basically says that the coverage in the policy is 90% of the medical benefits that would be provided. So in short, 70% of the average cost of covering the services under the insurance plan would be picked up by the plan, and the individuals would pick up 30%. So all the subsidies are geared to the silver level plan. So 71% of people who enroll in the exchanges are in the silver level plan. 23% are in the bronze level plan. These are cheaper plans because they cover less. They only cover 60% of the actuarial value of the benefits to be provided. The folks who participate in the exchange, who receive the premium tax credits, remember these are true up to 400% of the federal poverty line. That's 83% of all folks enrolled. So 5 out of 6 folks that enrolled are under that. And 58% receive subsidized deductibles and copays. So that's up to 250% of the federal poverty line. So you have a relatively poor population that had access when they didn't have before. Okay. Household incomes between 100 and 250% of the federal poverty line accounts for 71% of the enrollees. Household income between 251 and 400% of the poverty line accounts for 17% of the remaining enrollees. What's the difference? Well, the average monthly premium for the second lowest silver plan nationwide was $486 per month, okay? After the advanced premium tax credits, that premium falls to $101. Obviously, a huge difference. It makes it available to some people that wouldn't have been available previously. Okay, let's talk a little bit about the history of this. So in 2014, we had I think only one of the major insurance companies participated nationally in the plan. And we still enrolled over 8 million people, and we had a lot of variation across different places and where they enrolled. And the premiums were vastly different. When Dr. Norbaum and I started talking about these things, the premiums in Wisconsin were 3 times what the premiums were in Minnesota. Now, over time, lots of shifts in that. That no longer is the case. So, because of the large enrollment, a number of insurers participated the next year, but they weren't sure about who was going to enroll with them. So, many of them, we had an increase in enrollment up to 11.7 million, but many of the insurers lost money. So some of them dropped out in 2016 when we had 12.7 million and the premiums were raised. And then this year we have 12.2 million that have enrolled. And we probably would have had more than that, except the final push, the publicity to sign up before January 31st was abandoned by the Trump administration. They put out no publicity to encourage people to enroll. So up until certainly the numbers through December and even into the beginning part of January were ahead of the numbers for 2016. The bigger deal is a lot of insurers have dropped out, and I'll talk about why in a little bit. One of the major advantages of this act is previously people were locked into jobs if they had health insurance because they were worried if they left their job and they want to start a new business, they wouldn't have health insurance. Or they have to buy it on the open market, and if they had some kind of a condition, they would get very poor coverage and it'd be very expensive. So job lock, being locked into a job to get insurance was no longer there. That's important. The second result is that the premiums are inversely related to the number of participants in the market. No surprise there. Not an issue in Wisconsin because you have had pretty good participation. Some more history of the exchanges. The degree of competition, it varies not only across states, but within states. Quite a bit of variation across. For 2017, the rates, the second lowest average price silver plan, again, this is the one that the subsidies are tied to, increased by 22% over 2016. As a result, several things happen. Some plan switching takes place, move from higher price plans to lower price plans. With subsidies, remember 83% of the folks that are participating are getting subsidies, and the switching, the end result is the people who participated in these on average face the 4% premium increase. So yes, the list price went up for lots of folks by a lot, and really great variation across states. But for many of the enrollees, it didn't show up in the same way. Wisconsin has continued to have a lot of participation. So almost 140,000 in 2014, 184,000 almost in 2015, 224,000 2016, and the most recent number is 235,000. Now, one of the things about these numbers, the first three numbers are folks who actually enrolled and paid their premiums and stayed in. The last number is people who enrolled. We don't know that all those people have paid their premiums yet. Wisconsin counties have among the most stable of exchanges. And many of them are locally owned. The nationals don't play a big role. We have locally generated insurers, either from the providers or from insurers that basically insure within the state for much of it. So Marathon County, for example, this year has 4 insurers who offer plans and a total of 27 different plans that one can choose from. So that's not too bad. If you had, as an example, a family of 4 with 2 40-year-old parents and a $50,000 of family income, would get an advanced premium tax credit of $508, and with their and plus they'd get savings on deductibles and copays to a degree, and so the range of premiums would go from $256 a month to $533 a month. Not cheap, but still pretty good. The deductible range from the low end, this is going to come with the higher premium, $3,700, and for family deductible, and for the lower premium, $8,000. Now, each of these plans comes with a different network. It comes with different copays. It comes with different for what it costs for a doctor visit or what it costs for an ER visit and things of that sort, and different drug plans. Now, the biggest change, as I mentioned a little bit ago, is in the insurer participation. And what we can see, this is not relative to counties, but relative to people. So if we look at by decile, so if we take the lowest the 10% of the population that faced the lowest amount of coverage, the lowest amount of insurers, only in 2016, only 2% had one insurer choice. In 2017, 21% have only one insurer to choose from. That's a serious problem. Okay, now let me talk a little bit about some of the different markets and how they behaved, and there is a lot of variation here. So, as I mentioned, earlier, there's a lot of variation across markets and within markets. California and Michigan were very successful in generating a lot of competition in the marketplace. And premiums stayed down, and they got a lot of people enrolled. Florida, North Carolina, and Texas were much less successful. Now, one other distinction is the first 2 states adopted Medicaid expansion, and the last 3 did not. Medicare's they have a special waiver program, which has some interesting characteristics to it, but nevertheless, they expanded their program and got a lot of enrollment and got a lot of participation. It's important to recognize that medical markets are local. So one of the ideas that people talk about is the ability to purchase insurance across state lines. For the most part, that's not going to help because you still have to contract with local providers and local hospital networks, and being national doesn't help you with that local contracting. So there are large differences, as there are differences across each of the counties in Wisconsin and across each of the states as well. For many plans, the claims that were generated exceeded what they expected to have. Now, we do have within the Affordable Care Act 3 different risk transfer programs. And I'm not going to talk about those in detail unless you guys want to ask about it. One of them is really important. There's a transitional program called for risk corridors, which says basically above a certain amount, and it's calculated for each insurer and the enrollees they have, above a certain amount, they can get a transfer from the federal government to help them participate in the market, because you didn't know who was going to sign up with you. So to get insurers to participate, any insurer has to decide how risky it's going to be. Am I going to lose money? Do I have to have a premium high enough that I'm not going to lose money? If the federal government says, if you end up attracting expensive people, you're going to get helped out for several years until these markets stabilize. Well, unfortunately, that money's not there. And so a number of insurers are now suing the federal government to the tune of $8 billion, $8.3 billion, to try to make up for what they thought they had contracted for. So more complications. So what we've seen over time is the plans that were broad and basically said you could go to anybody have dropped out and been replaced by either very narrow networks. You can go to a relatively small set of doctors and hospitals and therefore get a lower premium, or you can have a very high deductible to get the premium down. One of those 2 ways is basically what's going on. One of the things that hasn't been talked about a great deal, though there's some recent work on this that I think is really interesting, is the amount of competition on the provider side, not the insurer side, but on the provider side, also varies a great deal across these markets. And that's important from a policy perspective. Okay, so are the exchanges in a death spiral? I would say maybe, okay? So enrollment growth appears to have stabilized, which makes it look like this is going to work. But it only works, and especially in the states where there's been Medicaid expansion. So the original numbers that the CBO, the Congressional Budget Office, put out for how many people would be insured are way low. And the primary reason is when they did their initial estimate, the presumption was the law, which said all the states expand Medicaid, got affected by the Supreme Court decision in 2012. So it's not the CBO's fault that their estimate's too high. It's a change in the circumstances. Competition has decreased in many markets, as I said a while ago, and there's a chart coming up which will show this. The nature of some markets, some states where there's only one insurer in the entire state that's participating. The risk pool basically attracts relatively poor and relatively unhealthy enrollees, because it's an option. They're going to sign up. They know they'll take advantage of it. And in fact, one of the concerns is people who may be healthy or who say, I don't want to spend the money, are going to say, well, if I really get sick, I'll be able to enroll. So they game the system in a sense, and that's part of the issue which the insurers are really worried about. As I mentioned a couple seconds ago, there's $8.3 billion of of funding. This is for 2014 and 2015 commitments that the insurers thought they were going to be covered for if they attracted a relatively expensive population. To make these markets hold, to keep the stability that we seem to have, there has to be a continuation of subsidies, both for the premiums and for the cost-sharing reductions, which I'll talk about in a bit more in a minute. Okay, what are the effects on health? Well, one of the things, it's too soon to be able to get a real sense of this. Nobody's really studied it yet, but we studied a similar program, not me, but economists have studied a similar program in Oregon, where they had a random assignment as to whether you were in Medicaid or not. And one of the effects, in my mind, the least important effect, is life expectancy between the two groups wasn't any different. But the bigger effect and the longer term effect is on going to see doctors and getting diagnosed if you have a chronic disease and getting that under control. Those are huge effects which don't play out in the short term, and in fact, they're costly in the short term. But over time, they really matter. The other thing is there's a lot of incentives which changed within the Affordable Care Act, especially on the Medicare side. So previously, if there was a bad result of, say, heart surgery and somebody's back in the hospital within 30 days, that's a new set of bills. Now it's not a new set of bills. There's an incentive to not have readmits. There's an incentive to have less in the way of infections. So there's a variety of different incentives that exist that have improved the quality of care. Okay, I'm not going to go through this chart. This is partly based on the Oregon stuff, partly based on some national data. The basic idea here is the folks with chronic disease are getting it diagnosed more quickly and consequently more likely to get it under control. Another result, I think this is an interesting one. So improved access to care. So on the horizontal axis, you've got a decline in the uninsurance rate between 2013 and 2015. So the further to the right you are, the larger the decline in the uninsurance rate. The vertical axis is the decline in the share not seeing a doctor due to cost. And you can see the upward slope. So the more the uninsured rate dropped, the more people could say, now I can afford to go see a doctor. And I think that's a really important result. And this comes out of a survey that's done annually called the Behavioral Risk Factor Surveillance Survey. And it's a nationwide survey that's done frequently. Okay, another result, this is hospital-acquired conditions or infections. And that's come down markedly as well. Again, this isn't per se because of the addition of insurance, but also the nature of the payment structure that's changed under the Medicare provisions within the ACA. And a drop in the readmit rate. Now, when I talk to my students about how to lie with statistics, this is a great example of how to do it. What you do is you make the drop look huge. How do you do that? Well, you don't have zero on the left-hand side of the graph, and you take small amounts of numbers and you spread them way out, and it looks like you got a huge drop. So, yes, this is a drop. It counts. It's important, but it gives you a sense that it's bigger than it actually is. Okay. There are still a lot of gaps, things to be repaired, fixed, etc. We don't attract a lot of young people. We don't attract healthy enrollees to the individual exchanges. Small businesses have had an opportunity to participate in the Small Business Health Options Program. I think there's fewer than 1 million enrollees in the entire country in that program. It hasn't been pushed, and it hasn't been used. It's got lots of really good incentives in it. We have insufficient funding to assist the insurers in participating in this volatile market. I talked about that a bit ago already. We have increased out-of-pocket burdens, especially for those with incomes more than 250% of the federal poverty line. And you saw the graph previously with the way the high deductibles have gone up. We have increased premiums and deductibles for non-poor, especially in the states that did not expand Medicaid, partly related to lack of insurer participation. Medicaid. The states that did not expand Medicaid, many of them do not have much insurer participation. So 5 states that only have one insurer participating in the market, Alabama, Arizona, Oklahoma, South Carolina, and Wyoming, only one of those, Arizona, was an expander. They have a waiver and they have a Medicaid program. So for a 40-year-old male, non-smoker who makes $30,000 a year before the tax credit, the advanceable premium tax credit, in non-Medicare expander states, the biggest cities in those states, their premium was $380 per month, and it went up by 28% from 2016 to 2017. In the Medicare expander states, the 31, it's $348, and it went up by 16%. This slide gives you a good sense of who has which insurers. So the orange ones are this is all by county, and you can get all these data at the county level. The orange states are the ones that have only, or the orange-colored counties are the ones that have only one insurer. So again, the ones I just highlighted for you, states like Wyoming, Oklahoma, South Carolina, states of that sort, Alabama, have only one insurer in the entire state. You might say Alaska, but if you look in the islands, the Nome and Juneau area, they've got more than one insurer, so it doesn't count, right? Okay, so what can we do about this? Well, there are a bunch of different options that we could do to help stabilize the market. We can continue doing what we're doing now, which is to continue to provide the premium subsidies to the folks below 400% of the poverty line, and the cost savings reductions for co-pays and deductibles. And I think we would stabilize where we're at. We could increase the penalties for lack of insurance. You may recall that the Trump-Ryan plan talked about a 30% penalty increase if you discontinued insurance and then you tried to get back in at a later date. So that's one kind of option. We can expand the age-related premium rate. So the band right now says somebody who's in the 55 to 64 group can't be charged more than 3 times somebody who's in the under 34 group. And the problem is the expenses are much wider than that. The expenses are roughly 5 to 1. So some kind of expansion of that will probably take place at some point. We could expand the reinsurance and risk adjustment provisions. Many people argue that's just subsidizing the insurance companies. Well, if you want them to participate until the markets get stable, they have to have a way to say, yes, I'm going to be able to do that and keep in business. They're not in a charity. They're not a charity. We could expand a public option. That would work if, A, you threw more money at it to make it cheaper, or they use their market power. And if they use their market power, it depends how they're going to buy. And as I'll say in a little bit later, as we go through the split that I'll talk about as to why we're not likely to get a national program, there's some problems with that. Okay, bottom line, we could create a separate risk pool. Bottom line for all this, somebody's got to pay more. So either younger people pay less and older people pay more, or you got to tax somebody. There really is no way around that. Okay, health savings accounts, which is a favorite of many people, many Republicans in particular, is a high deductible policy. The basic idea, and again, I'll talk about more this morning a little bit, the high deductible policy is to get people have more out of their, that they take responsibility for their own expenses. I call this the opium principle, for OPM, other people's money. People spend other people's money different than they spend their own. Now, there's a recent report out that says what some of the effects of these high deductible policies are. So this study, which was published in Health Affairs in February, essentially looks at 4 different companies that offered a variety of plans and looked at what plans people chose in 4 different wage groups. The lowest 25, the next 25, third 25, and the highest 25. And they find that people in the lowest group, the lowest wage group, have almost twice as many hospital admits, have more than 4 times as many avoidable hospital admits, have more than 3 times as many emergency room visits, and use preventive care about half as often. And so, bottom line out of this is if you increase the deductibles and you take away the cost-sharing reduction pieces, which affects relatively low-income people, this is what you're going to get. You're going to get a lot more push on the hospitals, which is why many of the hospitals are arguing against, and the American Hospital Association is arguing against weakening some of the provisions that are existent. So one of the things that actually I'm going to go to the next slide just in the interest of time. So this is a specific example of how it works with the cost-sharing reductions. So if you have income between 100 and 150% of the federal poverty level, then you qualify for the 94% actuarial value. So in short, you have 0 deductible in this plan. This is a particular one in Ohio. I think it's the Columbus area. So you have 0 deductible, an out-of-pocket max of $1,250 versus if you don't have any subsidy, it would be $7,150. Primary care office visit of 0, specialist visit at $10, emergency room visit at $150, et cetera. It's a huge deal. Okay, so what are we going to do? Reform and repeal and figure it out later, or just wait? Well, one of the things that exists presently, maybe not after today, is the law says that effectively for the Senate, you cannot repeal any of the provisions of an act except for the budgetary ones without 60 votes. Or they can filibuster, in short, as with the Supreme Court discussion. They can only, with a majority in both houses, deal with budgetary items. So many of the elements in the Affordable Care Act are of that sort, right? That they're not budgetary items per se, they're not federal budget items, so they cannot be easily repealed. What we've seen, of course, is the early participation in insurers was, here's a lot of people, maybe we can make some money, and then unless there's a lot of funding that will help us do it, we're not going to, this is a risk-losing proposition, so we're not going to play. We'll see more of that unless we have a change. And the more uncertainty there is, the more likely they are not to participate. Many of them have announced they're not going to participate this year and probably won't participate in the future. The one thing that the Trump administration did is bids were due by mid-May to participate in the 2018 exchange. Mid-May is only a little over a month away. They moved it to the end of June. I'm not sure how much that'll change if we don't have a better idea of what the policy is going to look like. The Republicans have proposed a 3-pronged approach: budget reconciliation, that is, do the things that are budget related because you only need a majority of vote, use executive authority, especially Health and Human Services, implementation codes and provisions, or total repeal. So there are, there we go, 6 potential routes the administration can use to undermine the ACA. One of them the House of Representatives passed a bill a while ago saying we have never funded the cost savings reduction piece. That piece which says if your income is less than 250% of the poverty line and you're participating in the exchanges, you get some extra help. This is $7 billion of extra help in the aggregate, okay? And effectively it would mean, there's just a report out that came today, which said on average that would mean a 19% increase in premiums if they took that away. That certainly will knock down the number of people who decide to participate. They could stop enforcing the individual mandate. They could refuse to publicize the exchanges. They did that in January. They could abandon funding for the risk corridors, the piece I talked about. They could abandon the lawsuits for the $8.3 billion to collect that and continue to do that. They continue to use the bully pulpit against the ACA. They can use HHS. Dr. Price, who now heads that organization, could use it to weaken the rules. One of the things they were talking about this week was to say maybe what we can do is give states the option to decide which of the essential benefits they'd like to implement. Three-legged stool, right? Okay. So we can get cheap insurance. If all we care about is cheap insurance, we can do that. That doesn't take much imagination. As the cartoon says, of course your insurance won't cover any medical expenses, but you must admit the premiums are attractive. All right. So let me move on to my piece of optimism first. There is a set of shared values that we could get around, that both Democrats, Republicans, and independents could agree on, that would get enough votes if somebody wanted to lead it, and it's doable, that would give us effective, sustainable reform. In fact, there was a poll which just came out 2 days ago, which said 75% of the public would support that, including 51% of Republicans. So what are those shared values? No pre-existing conditions exclusions, coverage of children until age 26, growth of expenditures on medical care in line with growth in GDP and in the economy, a viable, competitive, non-group insurance policy. People should be able to select a plan that matches their preferences and have public funding where appropriate based on income and age, and some degree of universal coverage and access. Actually, all of these are in the slides that Paul Ryan used in his infamous March 9th PowerPoint presentation. So it's not I'm making these up. So we could reach agreement in principle. Unfortunately, agreement in principle is not enough. What we're likely to have is competing interests and ideologies such that there's no overlap. And we have one group which believes effectively that we ought to have a defined benefit, and we have another group that believes that we ought to limit the contribution and the role of government and provide a certain fixed amount, and that should be it. Now, here's a slide that I'm told no one ever should use. It's got way too much on it, and we don't have time to go through it, so I'm going to flash it by you, and we'll come back if you want to talk about it. So here's the underlying arguments for this stuff, and I put them all on one slide for one primary reason. I want you to see the contrast in the two different viewpoints and why there's no overlap. And I'll just point out a couple different things. So essentially, the ideal for the folks who want to socialize healthcare, who believe in a defined benefit, is something like Medicare for all. And the ideal for the folks who believe that markets ought to drive things is that everything can be purchased the same way plastic surgery and LASIK surgery, and if you want to get a CAT scan for something, you buy it separately. That kind of thing. That's the main difference. And there's lots of stuff here. Again, there's not a lot of time to go through it. But I can come back to it if you want me to. Now, as I said before, I think there's a shared value solution that we could reach. We don't need the mandates. We can do what Medicare does presently. So if at 65, you choose not to sign up for Part B, even if you don't take it right away, and you wait till you're 68 when you retire, you get to pay an extra penalty. It's a 10% penalty. Something like that we could use as well. We could have the allowable age range change because not everybody who's 64 is poor. So let's separate the two. Let the premiums reflect what the underlying actuarial costs are and support the people whose income is relatively low. We could put a cap on the individual and family outlays as a percentage of their income. There is a part of the Affordable Care Act that has that. We could use a broad-based source of revenue to cover the rest, whether it's a general income tax or a value-added tax or whatever it might be. We could talk about that. We could replace the Cadillac tax, the tax on the expensive plans, with a cap on the exclusion of employer-sponsored insurance. We could use regulation and payment policy to limit the power of those insurers that they're the only ones in a given state, and the providers are the only major providers, or that nobody can have a plan without them in it in other places. We could combine the exchange and the non-exchange, non-group market into one market and have the subsidies available to all. One set of rules, not two different plans. Now, these ideas are a combination of ideas that come out of two places. The Urban Institute, which tends to be on the liberal side, and the American Enterprise Institute, which tends to be on the conservative side. Or we can just repeal. What we have discovered is this stuff isn't easy. And if you pull out one part of it, the whole thing may come crashing down. I'm almost done, really. If we're serious, we ought to ask the following questions. Who should pay for the predictably expensive? There are some people we know are going to be expensive. Many folks who have a chronic disease and it's not under control, that's going to be expensive. We need to decide how to deal with that. Which benefits should be required and which should be optional? If they're optional, then the folks who want them should pay for them. Whether that's states or individuals, again, it's a choice. What role should Medicaid have? Should it be like what Arkansas has done and say Medicaid should help relatively poor people? It should be integrated with the other markets. Right now, if your income in Wisconsin is $1 less than the federal poverty line, you get everything covered for free in your plan. If it's $1 over the federal poverty line, you participate in the exchange. And the gap is quite different. It's not smooth. So it gives people an incentive to say, well, I want to work, but not too much. What's the best way to reduce cost and growth of medical care? This is a very complex topic. And when can market competition work? When is it desirable? When is it feasible? All right, last major slide. So what are my conclusions out of all this stuff? Sustainable, cost-effective, and equitable reforms won't take place if partisan interests dictate reforms. That's what we had in 2010. That's what we have now. Greater savings, improved efficiency, and reduced inequities can come from capping or maybe even eliminating the $3.6 trillion commitment to tax-exempt employer-sponsored insurance. That's real popular politically, I'm sure you know. Most of that, as I said, $150 billion currently per year goes to the top 30% in income. The role of competition in clinical care delivery markets has been woefully neglected by most of the partisans. They haven't talked about it. It matters a lot. It should be looked at. I'm not optimistic, if you haven't gathered, about improvements in health policy legislation at either the national or state level. But, to end on an optimistic note, there exists potential at local levels to craft initiatives to better allocate resources to those determinants of health that have the greatest effect on both health and spending. We need to rethink health. That's a cue to Tim to key up this short little video.
The American health system is big, complicated, expensive, and it can be much better than it is. When we think of our health system, most people think of doctors, hospitals, insurance, drugs, patients. But really, anything that affects our health is part of that same system. We all need things like clean air, healthy food, safe neighborhoods, quality education, good jobs. But too many of us don't have these advantages. Behind the scenes, everything has to work well and work together as a system for everyone to be healthy and productive, get the care they need, and keep costs down. The problem is, it doesn't. In fact, many challenges are getting worse. What will it take to change direction? People everywhere are scrambling for solutions. They're trying to expand insurance, deliver better care, cut costs, change payment, and finding ways to create healthier conditions in homes, schools, workplaces, and neighborhoods.
Thank you for listening. Happy to take questions. Not all at once, though.
So, do you have any faith that there ever could be a market solution for healthcare? It sounds like you were very skeptical of the notion that we could have consumers making choices and rationing themselves, because healthcare really doesn't lend itself to that. So,
my answer is yes, but that market's a complicated market. There's several markets. What people need to make good decisions is to have good counseling. And so for me, that means we need an incentive structure so that the healthcare system and patients are on the same financial page. And they both win by doing the right thing. So it's not a matter of saying, here's the stuff you can find on the internet, go to WebMD, and we'll give you a high deductible policies and you figure out what you want. That's not going to work, because even for those of us who spend a lot of our time thinking about these kinds of things, it's a very complex set of things. So you need someone effectively who's an advocate for you but has your interest in mind. I think the role of primary care provider is critical in that. So with that, I don't see any reason why you can't have competition. Yes?
I'm wondering how much profit is reasonable, and when insurance companies are pulling out of states, do we know how much profit has been made or has not been made?
Well, we know that most of the commercial insurers, did everybody hear the question? We know that most of the commercial insurers have lost money in the exchanges. And they've lost money, the national commercial insurers. And I think they've lost money because they're trying to provide a product which has a broad character to it. And that's not the way healthcare markets work. Healthcare markets are very local. So they're not participating because the kind of product they have developed historically doesn't really meet the kinds of needs that we have presently. So it's not that they're not, if they were making money, they would stay in. They're not going to do it out of charity. So, and over time, if we want the commercial insurers to participate, we have to make it attractive in such a way that they don't make too much. Now, there's part of the Affordable Care Act which essentially says any insurer in any state, right, that for which in dealing with large groups, they have, they're not paying out at least 85% of the premium, they have to give back the rest of it. And for small groups, if they're not paying out at least 80% of the premium, they have to give it back. Now, it gets more complicated than that because some of the insurers are pretty good at helping to manage health where others are not. And so it looks like an insurer expense, and that's part of that 15 or 20% because it shows up as part of the administrative costs. So it's a complicated question. We do have a provision in the law, in the ACA, which addresses what you want, however.
One of your earlier slides had the United States in a red dot at the far end of that graph.
Right.
Can you speak to what you see puts us in that position as opposed to those other countries? You know, we're talking 10,000 foot type level.
Yeah. I think, well, each of those other countries has universal coverage. We do not. That's step one. Secondly, we're largely driven by a fee-for-service system. The more you do, the more you get paid. That doesn't per se differentiate us from Canada or France or Germany. But what they tend to have, different systems in different places. In Canada, they basically have a given budget. Stated differently, don't get sick in December unless you have a priority disease. Because physicians can only bill up to a certain amount against that budget, that income target. And if they bill beyond that, they don't get compensated for that. So each system has its own problems and own ways to do things. All of them pretty much have something which caps the amount of expenditures that go in the system one way or another. We don't. Now, caps come with trade-offs. So if you're going to set the caps at the national level, or you're going to let Tom Price set the caps, play on words, right? Price caps. You know, there's going to be a lot of money for orthopedic surgery, but it's not clear that that matches the preferences of the population. So each of the systems, and I've done some work comparing across countries, especially the British system, they all have different ways they figured out how to limit what you can get. So the British have basically said, we're not going to educate, for example, many nephrologists. So we don't need to buy a lot of equipment that the nephrologists are going to use. Now, over time, as the cost of that equipment come down, then they might add some of that. But it's not going to be that easy. So they make decisions of that sort, and they make it at a high level. We don't do that. In fact, we go even much further. We will not even allow in the discussion of what services get offered cost to be a consideration at the policy level. So it becomes very difficult to figure out, am I getting value for money or not? How do you design a plan when you can't get at that information very easily? So we've got all sorts of ways that we differ from everybody else. Each of those piles on to putting that dot further to the right. Follow up. And then there's a question down here.
So if I can summarize what you mentioned about the general flavor or characteristics of plans in those other countries, rationing would be one way to explain the things you call limits to expenditures.
You're always going to have rationing. The question is who gets to do it?
But my point is we don't have rationing.
Oh, we do.
Do.
But it's rationing by income.
Okay. But rationing for expenditures.
Now, one of the things that's being explored, Medicare in particular, actually, here's another piece of optimism for you, right? There's a bill called MACRA, the Medicare Advantage and Child Health Improvement, I forget the CHIP Reauthorization Act, which was passed in 2015 by a vast majority of both houses of Congress. Even Tom Price voted for it, the Health and Human Services Secretary. And it says Medicare is going to pay differently in the future, and it's going to take into account, through a couple different systems, the value of what's being produced. This is going to lead to a sea change over time. Not going to happen instantly, but it will happen over time. It'll be a big deal. So that's my other moment of optimism, I guess, for the evening. Question in the front here.
It seems like the most popular part of the health insurance system is Medicare. People like Medicare and don't let the government get their hands on my Medicare, right? And they can choose Medicare Advantage. So there's a choice, there's competition, there's free enterprise there. And that's the part that the Republicans are working to eliminate and replace it with something that looks very much like Obamacare for under 65. I mean, the Paul Ryan Medicare plan gets rid of Medicare and replaces it with basically Obamacare, which is evil under age 65. And then people don't really like the under age 65 market a whole lot unless they work for a paternalistic employer, which doesn't really much exist anymore. So doesn't it seem like somehow our public policy is going the opposite direction from the systems that people enjoy, being the universal coverage with
right.
A private option?
Yeah. So when Medicare was passed in 1965, it was passed, the AMA was willing to sign on to it as long as it had two major provisions. You can go to anybody you want and Medicare will pay, and it's got to be fee-for-service. In the 1980s, recognizing that wasn't doable, people decided to live longer for some odd reason. And that wasn't doable as a viable plan, so we introduced the prospective payment system, known as DRGs. That stands for Dirty Rotten stands for Diagnosis-Related Groups. Okay? And that's prospective payment, paying a fixed amount for a package, whether you do more or less. The Medicare Advantage program, which is a variation on Medicare Plus Choice and some other things we've had since the Kennedy-Kassebaum bill in 1996, essentially is a move to a plan which is not open-ended. You can't go to anybody you want. There are some restrictions. There's some encouragement. We've passed some legislation which encourages preventive services, and we have a little more. We're trying to get more coordinated care. The accountable care organizations. The idea is to coordinate across different parts of the medical care system, so it's not like my mother did, which is to go to somebody different for everything that she was troubled by. And so she was sitting with 13 different medicines and nobody was watching over the whole story. That's the Medicare we created in 1965. It doesn't fit today's world. So we can't just, there are people in the political sphere who'd like us to go back to the future. That's not an option. Technology means it's not an option. The British discovered that their rationing system worked until technology progressed and they couldn't afford it. But they couldn't afford the things that were helping people get better. And that, you get voted out of office when that happens. So I'm not sure I agree with some of the premises, but I will of your question, but I will argue that Medicare has to change too. And politically, I'm not sure that Ryan's plan and the plans that they will come up with will go anywhere near Medicare. They don't need more heat, I don't think. They're not looking for more controversy. They can't even agree on some basic stuff.
I know you've touched on this, Dr. Finkler, but Are there incentives in the healthcare system to move more towards fee-for-value versus fee-for-service?
Yeah, I mean, there are two programs that, I even have the name of it here somewhere if I can grab it quickly. The MACRA Act, the one I mentioned a bit ago, has two different programs. Medicare's intent was by 2018 to get at least half of the payments on a non-fee-for-service basis, half of what their payout. They have a merit-based incentive payment system, and they have one that's called Advanced Alternative Payment Models. And both are an attempt to do precisely what you're saying. They do it in different ways. One of them is a little slower approach than the other. And effectively, it's to introduce incentives that you get paid more for doing certain kinds of things, for which there's evidence that it works, that health improves, and do less of the things for which there's no improvement in health. But eventually we have to make a decision. You know, how much do we want to spend to extend people's lives another 3 months when the quality of life they're going to have is not that great? And if it's out of your pocket, fine. If it's out of the public pocket, that's a different decision. And it's a decision that politically we have no way to cope with. Any other questions? Thank you so much for your time and attention.